So let's talk about the cardiovascular embryology. So basically, heart is the first functional organ in the vertebrate embryo which starts beating spontaneously on the fourth week of development. So coming back to the morphogenesis of the heart, it is divided into four stages basically. The first stage is cardiac looping, which shows the right-left polarity of the heart, and which starts again in the fourth week of development. And the next step is separation of the chambers, like atria and ventricles, the development of the outflow tract and the valves. So these are the stages, and we'll discuss them in details now. So cardiac looping, it starts around the week 4 of development, and it establishes the left-right polarity of the heart. So basically, the primary heart tube, it we can see here, the primary heart tube starts developing, and you can see the various parts of the primary heart tubes here. On the 22nd day, you can see here, the 22nd day, this is the primary heart tube. We can see the first aortic arch developing, the sinus horns, and the cardinal veins. These are the structures. And also this part is known as the bulbus cordis. You can see bulbus cordis. And this is the primitive ventricle. It is going to be developed into the primitive ventricle, and these structures are going to be developed into the primitive atrium. So what happens is, from 22nd day to 24th day, you can see there is a development of the pericardial sac. You can see this is the pericardium. Then you will see the ventricle starts rotating. There is a rotation. You can see the arrows here. This rotation basically signifies the cardiac looping. Due to this looping, the atrium, you can see this is the atrium, and this is going upwards. Okay, and the ventricles along with the bulbus cordis, this will be going downwards. So this is the cardiac looping happening here. So clinically, there is a condition where there is a defect in the left-right dynein protein, and this left-right dynein is actually involved in the left and right asymmetry of the heart. And if there is a defect in that, it will lead to dextrocardia, that is right-sided heart. So this dextrocardia, which we see in Carter-Jenner syndrome. Carter-Jenner syndrome. Now just remember this picture here. We'll remember this picture. We can see the aortic roots, we can see the bulbus cordis, we can see the ventricle, we can see the atrium, and the pericardial sac, and the truncus arteriosus we can see here. So now we'll go and see what happens next. Now we are looking at a heart which is 35 days of intrauterine life. So we can see the truncus arteriosus part has given rise to the vascular outflow tract, right? So this is the primitive left atrium. You can see the pericardial sac outside, and this is the left ventricle developing, you can see. And on the 50th day of intrauterine life, you can see the structure similar to the adult heart. So this is the right atrium, this is the left atrium, these are the ventricles, and you can see the aorta, ascending aorta, aortic arch, superior vena cava, pulmonary trunk, and all other things are developed properly. So let's discuss the structures which are basically developed here. So the first structure is the truncus arteriosus. So let's identify the truncus arteriosus here. So basically, truncus arteriosus, it comes around, you can see here. So this is the truncus arteriosus. So truncus arteriosus, it comes here. You can see this is the truncus arteriosus. And in the next 35 days, you can see this is the truncus arteriosus. And this is the part develops into. Okay. So what are the parts which truncus arteriosus gives rise to? As you can see in the picture, it gives rise to ascending aorta and the pulmonary trunk. Pulmonary trunk. See, this is the ascending aorta and this is the pulmonary trunk which it gives rise to. Our next structure is bulbus cordis, means this area, and turning into this. So bulbus cordis. Now let's see where it is. So you can see the bulbus cordis here and here, right? So as we see in the picture, it gives rise to the smooth outflow tract of left and right ventricles, of both of the ventricles. The next part is sinus venosus. So these are the sinus horns. You can see this basically is the sinus venosus. So this part, what it gives rise to, let's see. So basically you can see the sinus venosus has two horns. Okay, so one is the left horn, one is the right horn. So what they gives rise to, let's see. So the left horn of the sinus venosus gives rise to coronary sinus. So it gives rise to coronary sinus, and the right horn, it gives rise to the sinus venerum, or the smooth part of the right atrium. So right atrium, smooth part. So what gives rise to the smooth part of the left atrium? Left atrium smooth part is given by the primitive pulmonary vein. Okay. Now there is a very important structure which we will know in details. It is called endocardial cushion, and what structures it gives rise to, we must know now. So atrial septum and the interventricular septum only the membranous part. Interventricular septum we will know has a muscular part and the membranous part. So the membranous part comes from the endocardial cushion. And two valves, the atrioventricular valves, AV, and the semilunar valves. They are coming from this endocardial cushion. Very important. So now about the cardinal veins. So these are the structures known as the cardinal veins. So what structures do they give rise to? So basically cardinal veins gives rise to superior vena cava and the inferior vena cava. But there are so many cardinal veins, so we have to know the superior vena cava is given by the right common and right anterior cardinal vein. So this is the point to remember. And inferior vena cava is given by the posterior cardinal vein, subcardinal vein, and supracardinal vein. Now, after the events of the cardiac looping has been started, we'll see what happens inside the heart. So, separation of the chambers are occurring. So, in atria, the first thing that occurs is development of the septum primum. You can see here, this is the septum primum which is developing. And it grows towards the endocardial cushions. So, this structure is known as the endocardial cushion, and septum primum tends to grow towards it. And this, as you are seeing in the image, it is known as the ostium primum. This is the ostium, an opening which is there, that is known as the ostium primum. So basically this is the first step. In the second step, as the ostium primum was growing, the septum primum was growing towards the endocardial cushion, there is now regression or atrophy in the septum primum due to cell death. Now this cell death leads to form of another ostium. So this is the ostium primum, we can see here, this is the ostium primum, it was there, and now another ostium has developed due to cell death in the septum primum, and this is known as the ostium secundum. Through this ostium primum and the secundum, there is right to left shunt that is going on in the fetal circulation. Now in the third step, you can see the ostium primum which was there, it is now regressed because the septum primum has fused with the endocardial cushion, and you can see the ostium secundum is there which is maintaining the right to left shunt. Now what happens? Another septum that is growing on the right side of the septum primum, and this is known as septum secundum. Now the septum secundum, it expands and almost covers the ostium secundum which was there, leaving a little bit of gap in between them, and that gap is known as the foramen ovale, and this foramen ovale maintains the right to left shunt. And you can notice the remaining portion of the septum primum, it forms a valve for the foramen ovale, a valve that only allows right to left shunt. Now slowly the septum primum above, it degenerates, this part, and this part acts as a valve as we have discussed already. And at birth what happens, this valve, it fuses with the septum secundum, and the foramen ovale gets closed, and then we call this remnant of the foramen ovale as fossa ovalis. And the septum primum and the secundum, they fuse throughout the infancy to form the atrial septum. So how does foramen ovale close? Physiologically, at birth the baby takes the inspiration, which results in decreased resistance in the pulmonary vessels. So definitely pulmonary resistance, if it goes down, the right atrial pressure will be going down, and the right atrial pressure is less than the left atrial pressure. So what will happen? You can see in the image, suppose here the pressure is less, right atrium, the pressure is high in the left atrium. So what will happen here? This septum primum will definitely be pushed towards the septum secundum, right? So this will close the foramen ovale. So now if there is impairment in this closing of the foramen ovale, so this is going to lead to the patent foramen ovale, and this can cause paradoxical embolization, in which the venous thromboemboli can enter into the systemic arterial circulation because there is a patent right to left shunt which was not supposed to be there. So this can lead to paradoxical embolization. Another condition that can lead to the paradoxical embolization is atrial septal defect. So now let's see what happens in the ventricles. So in ventricles, a muscular interventricular septum develops. So this is the interventricular septum that you can see here, and the foramen that is there is known as the interventricular foramen. You can see these are the atrioventricular canals through which the atriums are connected with the ventricle. So in the next stage, what happens? The neural crest cells, they migrate to form a structure known as aorticopulmonary septum. You can see it here. This structure is known as the aorticopulmonary septum. So what is happening here? It rotates. Basically, you can see it is a twisted or a spiral structure. You can see it is twisted here. So there is a rotation of this aorticopulmonary septum that occurs, and then it fuses with the muscular ventricular septum. This muscular ventricular septum will go up, this will come down, and they will fuse to form the membranous part of the ventricular septum. So the interventricular foramen will be closed. So you can see here it has formed the membranous interventricular septum here, and there is another structure we have discussed before, that is the endocardial cushions, and these endocardial cushions will grow and they will separate the atria to atrias from the ventricles, the endocardial cushion, and definitely it will also contribute to the membranous septum as we have discussed in previous slides. So clinically what we must know is the most common congenital cardiac anomaly is known as the ventricular septal defect, and when it occurs in the membranous interventricular septum area. Now about the outflow tracts. As we have discussed, the neural crest cells, they migrate to form the aorticopulmonary septum. They migrate to form the aorticopulmonary septum, and this septum has two ridges. One is truncal ridge, another is bulbar ridge. So these two ridges, they become a spiral structure. They rotate and fuse to form the septum, and then they will form the ascending aorta from the inside and the pulmonary trunk. So if there is any abnormality in this process, we call it as a conotruncal abnormality that occurs due to failure of the neural crest cells to migrate basically, and it will lead to transposition of greater arteries, or it can give rise to tetralogy of Fallot, or it can also lead to persistent truncus arteriosus. So now about the development of the valves. So aortic and pulmonary valves, they basically derive from the endocardial cushion of the outflow tract, and mitral and tricuspid valves, they are derived from fused endocardial cushions of the AV canal, atrioventricular canal, that we have seen in the picture. Congenital valvular anomalies, they can be valvular stenosis, they can be valvular regurgitant lesions causing regurgitation, they can be atretic causing atresia, they can be displacement of valves like seen in Epstein's anomaly. So this is the clinical significance. Now another important topic, that is the aortic arch, and this aortic arches, they give rise to various structures that we must know. So this is the basic structures that we must know from which arches they develop. This is very important. You can see this is the arch of the aorta. You can see this is the arch of the aorta here, and you can see the structures coming, the common carotid artery and the internal carotid artery, external carotid artery, and the subclavian artery. These things you can see here. So let's see which part develops from which arch. So there are basically 5 arches. There is a 1, 2, 3, first arch, second arch, third arch, fourth arch, and sixth arch. There is no fifth arch with regresses basically. So let's see the most important arches first. The fourth arch and the sixth arch. So they both have right and left sides. So right fourth arch, it develops the right subclavian artery, proximal part. Very important. The proximal part of the right subclavian artery is by right side of the fourth aortic arch. On the left side, it gives rise to the aortic arch. Left side, fourth arch gives rise to the aortic arch. For the sixth, the proximal part of the pulmonary arteries, it gives rise to the proximal part of pulmonary arteries, and on the left only, it gives rise to ductus arteriosus. So basically sixth arch, it gives rise to the pulmonary arteries and the pulmonary shunts, pulmonary to systemic shunt, that is the ductus arteriosus, which later will close and give rise to the ligamentum arteriosum. First arch gives rise to the maxillary artery, which is a branch of the external carotid. The second arch gives rise to the stapedial artery and hyoid artery. The third arch gives rise to the common carotid artery and proximal part of the internal carotid artery. You can see the third arch, it gives rise to this. This is the common carotid artery. And the internal carotid artery. You can see both sides. This is internal carotid, common carotid. Okay. The next is the fourth arch. You can see the fourth arch gives rise to, on left, it gives rise to the aortic arch, and on the right, it gives rise to the proximal part of the right subclavian artery. So this is the right subclavian artery. You can see. So here you must remember one clinical importance, that is the right recurrent laryngeal nerve. It loops around the subclavian artery. So right recurrent laryngeal nerve loops around the subclavian artery. Now about the derivatives of the sixth arch. You can see sixth arch gives rise to the proximal part of the pulmonary artery, and on the left only it gives rise to the ductus arteriosus. And the thing that we must remember is the left recurrent laryngeal nerve, it loops around the sixth arch or ductus arteriosus. So what happens at birth is there is respiration causing the increase in oxygen in the fetal circulation, and the placental separation which occurs, they decrease the prostaglandins, like specifically E1 and E2. And these two factors lead to closure of the ductus arteriosus. So if by any means this process is impaired, there will be patent ductus arteriosus, PDA. Okay. For this, we can use indomethacin and ibuprofen. They are NSAIDs, and we can use NSAIDs to close the ductus arteriosus. So this is all about the cardiac embryology. Hope this helps. Thank you for watching. See you next time. And subscribe to the channel would be great.